World Medicine Universitet. 2017. Rosacea Current Medical Therapeutics. As with acne vulgaris, multiple topical and oral agents have been tried over the years for the treatment of rosacea. In fact, a large portion of the medications introduced in Chapter 2 of this book have been successfully utilized in rosacea, Table 7. These are especially important in the treatment of the acne-rosacea overlap, where clinical components of both diseases coexist in the same patient. On the other hand, additional therapeutic agents that may improve one disorder may not be useful in or even aggravate the other disease. Tables 8, 9. Rather than repeat the information already contained in a prior chapter, this chapter will focus mainly on the medications found to be of exclusive value in the treatment of rosacea and will only briefly touch on the previously covered, but otherwise useful, rosacea agents. For the latter group of medications, the reader is invited to revisit the appropriate sections of Chapter 2. In addition, wherever available, current information on the proposed mechanism of action of the therapeutic agents will also be presented. Although efficacious in the treatment of papulopustular rosacea, both oral and topical agents tend to have less of an impact on the erythema of erythematotelangiectatic rosacea, and even so on telangiectasias. On the other hand, vascular-specific lasers may be especially useful in such presentations and will be covered in Chapter 7. General considerations. Before the forthcoming discussion on topical and oral therapeutics in rosacea, some important general considerations will now be addressed. First, patient exposure to rosacea triggers, as presented in the previous chapter, must be minimized. Thus, patients should be educated on the avoidance of their specific flushing stimuli. Additionally, the National Rosacea Society, which can be found on the internet at www.rosacea.org, is an excellent educational resource for the patients. General skincare should be addressed early on in the treatment of the disease. As mentioned in the previous chapter, poor tolerability of topical products is commonly encountered in rosacea, especially the ET subtype. The resultant irritant dermatitis typically presents as roughness and scaling, sometimes accompanied by itching, burning, or stinging. Thus, the selection of non-irritating cleansers, moisturizers, and makeup is essential, as harsh daily skincare regimens may negatively affect skin barrier function. Some patients may also benefit from the use of green-tinted moisturizers and other green-colored cosmetics, as these tend to camouflage excessive facial redness. A tank-colored foundation can then be applied to match the patient's desired skin tone. Finally, photoprotection is advocated by many practitioners. However, the exact role of ultraviolet radiation in the pathogenesis of rosacea is still debated. When utilized, sunblocks containing zinc oxide or titanium dioxide tend to be well tolerated by rosacea patients. Topical agents. As with acne vulgaris, topical agents may be used alone or in combination with oral agents for maximum effect, especially during acute flares of the disease. In addition, topical therapy is generally required for long-term maintenance of remission. As mentioned above, rosacea patients may experience significant skin irritability, occasionally necessitating a discontinuation of the very same medications typically prescribed to improve the condition. This distinctive feature of the disease should be considered whenever a flare is observed with a new topical agent, especially if accompanied by itching, burning, or stinging. Antibiotics. Metronidazole is one of the most commonly used topical agents in the treatment of rosacea. Although infrequently used in this condition, the oral form is also available for the more severe or recalcitrant cases. Topical metronidazole is available in different countries in a gel, cream, and lotion formulations, with concentrations ranging from 0.75 to 1%. Formulations may be used daily to twice daily. A combination of topical metronidazole cream and sunscreen is also available outside the US. Oral metronidazole is available in 200 mg, 250 mg, 400 mg, and 500 mg tablets, as well as 750 mg extended-release tablets. The original study by Pai and Burton utilized a 200 mg dose taken twice daily, while later studies used a total of 500 mg per day. Metronidazole is a synthetic nitroimidazole antibiotic. It is active against a variety of gram-positive and gram-negative, as well as some anaerobic bacteria and certain protozoans, likely through the disruption of microbial DNA. However, its role in the treatment of rosacea appears to involve a different mechanism of action, as bacteria are unlikely to be involved in the pathophysiology of the condition. Thus, it has been demonstrated that metronidazole possesses significant anti-inflammatory properties in the skin. Specifically, the agent was found to modulate neutrophil function by suppressing neutrophil-generated reactive oxygen species in a dose-related manner. More recently, inherent ROS scavenging and inactivating properties of metronidazole were also demonstrated in a skin lipid model. Systemic absorption following cutaneous application appears to be very low. On the other hand, oral bioavailability of metronidazole is very high at over 90%. It is widely distributed following oral administration, including into breast milk and across the placenta. Studies on such distribution following cutaneous application to intact skin are lacking. Adverse effects following topical application to skin are few and typically include symptoms of localized irritant dermatitis. Rare cases of allergic contact dermatitis have also been documented. On the other hand, adverse effects associated with oral administration of metronidazole are fairly numerous and potentially serious, but are more frequent at higher doses and with long-term therapy. These may include seizures, peripheral neuropathy, nausea, metallic taste, headaches, and various hypersensitivity reactions. In addition, oral metronidazole potentiates the anticoagulant effect of warfarin. However, the previously accepted notion of a disulfiram-like reaction when the agent is co-administered with alcohol has recently been challenged. Finally, it has been suggested that oral metronidazole and its metabolites may be mutagenic, though evidence from human studies is insufficient at this time. Metronidazole in both topical and oral forms is an FDA Pregnancy Category B agent. It is excreted in breast milk following oral, but not topical, administration. Topical clindamycin may also used in the treatment of inflammatory papules and pustules associated with rosacea. It is available in numerous formulations containing 1% clindamycin phosphate, including solutions, lotions, gels, and foams. In the treatment of rosacea, the gel preparation is usually tolerated better and is typically administered once to twice daily. Clindamycin belongs to lincosamide family of antibacterial agents, though its mechanism of action in rosacea has not been studied directly. Recently, however, an in vitro study demonstrated a direct scavenging effect of clindamycin phosphate on hydroxyl radicals, suggesting a potential antioxidant action in rosacea. The systemic absorption, pharmacology, and adverse effects of clindamycin have been covered extensively in a prior chapter. Topical clindamycin is an FDA pregnancy Category B agent. The topical agent appears to be safe in lactating women, as no adverse effects have been documented in the infants of such patients. Azelaic acid. Azelaic acid is a 9-carbon chain dicarboxylic acid derived from Pityrosporum ovale. It is available as a 20% cream and, more recently, as a 15% gel. Although both formulations have been successfully used in the treatment of inflammatory rosacea, the cream preparation contains significantly larger amounts of emulsifiers, which may lead to a greater potential for skin irritation. Additionally, the amount of the active ingredient delivered to the skin has been found to be significantly greater using the gel formulation than using the cream. While the traditional rosacea regimen called for twice-daily application of azelaic acid, the efficacy of once-daily administration has also been documented and may be associated with greater patient tolerability and dosing flexibility. The mechanism of action of azelaic acid in the treatment of rosacea has not been completely elucidated. As mentioned in Chapter 2, the agent has anti-proliferative, antibacterial, and anti-keratinizing properties. However, these actions are unlikely to account for the improvement noted in rosacea. Instead, similar to metronidazole, azelaic acid appears to be a potent inhibitor of neutrophil-generated ROS and to possess free radical scavenging properties. Although only local application site adverse effects have been reported with topical azelaic acid, these appear to be somewhat more frequent than with topical metronidazole. Pruritus, stinging, burning, erythema, and peeling are encountered most commonly. Azelaic acid is an FDA pregnancy Category B agent. Since azelaic acid is normally present in most diets from its natural occurrence in cereals and other products, topical application of the agent is likely safe during lactation. Sodium sulfacetamide and sulfur. These agents were introduced in Chapter 2 as effective therapeutic agents in the treatment of acne vulgaris. Likewise, both sodium sulfacetamide and sulfur have a long history of use in inflammatory rosacea. Their mechanism of action in this condition is, however, unclear, but may involve anti-inflammatory properties of both agents. The combination of the two agents is available outside of the UK in a number of creams, lotions, gels, suspensions, cleansers, and masks. The concentrations of these ingredients may vary, though a combination of 10% sodium sulfacetamide and 5% sulfur is encountered most commonly. These products are now experiencing resurgence due to the recent availability of odor-masking formulations. Once to twice daily application regimen is most commonly used in the treatment of rosacea. Adverse effects following topical application of sodium sulfacetamide/sulfur combination products are generally mild and limited to localized irritant dermatitis with erythema, itching, burning, itching, and scaling. The incidence of such reactions appears to be somewhat higher compared to those from topical metronidazole. Although sulfur does not cross-react with sulfonamides, sodium sulfacetamide does, making the combination contraindicated in patients with allergic reactions to sulfa drugs. Both topical sulfur and sodium sulfacetamide are FDA pregnancy Category C agents. Although the excretion in breast milk has not been studied with either, an increased risk of kernicterus in nursing infants has been documented with oral administration of sulfonamides. Retinoids. As introduced in Chapter 2, retinoids are used extensively in the treatment of acne vulgaris. Though their use in rosacea is significantly less common, it has been evaluated in several studies. The mechanism of action of retinoids in rosacea is not completely clear. Various anti-inflammatory properties of retinoids, including an antioxidant effect on the neutrophil system, have been demonstrated. It has also been suggested that an additional mechanism may involve downregulation of angiogenesis associated with the disease. To that effect, it has been shown that retinoids have an inhibitory effect on the expression of vascular endothelial growth factor and its receptor, though this effect is not mediated by the retinoic acid receptors. Future studies will need to determine whether additional anti-inflammatory or anti-proliferative properties of retinoids may be involved in the improvement of symptoms and signs of rosacea. Although multiple formulations of retinoids are currently on the market, tazarotene is rarely used in rosacea due to its somewhat higher potential for local irritation. Other topical retinoids currently available in different formulations in different countries include tretinoin and adapalene. Tretinoin is available in cream, solution, and gel forms, with concentrations ranging from 0.01% to 0.1%. Slightly less irritating microsphere and delayed release gel preparations are also available in some countries. Adapalene is available as a 0.1% cream, solution, and gel, as well as a 0.3% gel. Retinoids are typically used once daily, most commonly at night. This is especially important for tretinoin, which is photolabel. Adverse effects associated with the use of topical retinoids in the treatment of rosacea are generally limited to localized irritation. This typically manifests as erythema and scaling, as well as pruritus, burning, or stinging. Adapalene may be associated with a slightly reduced risk of these side effects, as is tretinoin incorporated into microspheres or into a polyol prepolymer 2 gel. Both topical tretinoin and adapalene are FDA Pregnancy Category C agents. Though not extensively studied, their use during lactation is inadvisable. Oral agents. Oral agents are frequently utilized as part of a multi-agent regimen in the setting of acute rosacea flares. 59, 60. Once the flare has resolved, the oral agent may be discontinued, with remission maintained through the use of topical therapies, as described above. Antibiotics. Among the oral agents used in the treatment of rosacea, the tetracycline family of antibiotics is employed most often. With rising concerns about the emergence of resistant bacterial strains, the recognition of anti-inflammatory properties of these agents with subsequent development of lower dose regimens represents an important therapeutic advancement. The most commonly used agents in this category include tetracycline, minocycline, and doxycycline. Tetracycline is available as 250 mg or 500 mg tablets or capsules, usually taken twice daily. Minocycline is formulated as capsules or tablets, with doses ranging from 50 to 100 mg twice daily. Finally, doxycycline is available in capsules, tablets, and enteric-coated tablets in 20, 50, 75, and 100 mg dosages typically administered twice daily. Additionally, a 40 mg once daily formulation, containing 30 mg of immediate release and 10 mg of delayed release doxycycline, is now available and has been approved by the FDA for this condition. As the name implies, tetracyclines feature a tetracyclic naphthacene carboxamide ring structure. While their antibacterial activity has been appreciated for decades, the anti-inflammatory properties of these agents have only recently been recognized. In the process, tetracyclines have been shown to affect many of the inflammatory pathways thought to be involved in the pathogenesis of rosacea. Thus, these agents have been shown to inhibit neutrophil chemotaxis and neutrophil generation of ROS, to scavenge for free radicals, to inhibit matrix metalloproteinases, to upregulate anti-inflammatory cytokines, and to downregulate pro-inflammatory cytokines. Furthermore, both minocycline and doxycycline have been shown to inhibit VEGF-induced angiogenesis, which may, at least partially, be responsible for the formation of telangiectasias in rosacea. The pharmacokinetics, adverse effects, and drug interactions of the tetracycline family of antibiotics have been extensively covered in Chapter 2 of this lesson. The reader may wish to review the corresponding section of that chapter at this time. Tetracyclines have important adverse effects on the developing bones and teeth, thus, all are designated as FDA Pregnancy Category D agents. Tetracyclines are also excreted in breast milk and are, therefore, contraindicated in nursing mothers. Azithromycin is a macrolide antibiotic with known antibacterial, as well as anti-inflammatory, properties. It has also been used for the treatment of rosacea, though, due in part to its long half-life, various regimens have been employed. Azithromycin is available as 250, 500, and 600 mg tablets, 250 mg and 500 mg capsules, as powder for oral suspension, and as an extended-release oral suspension. Multiple anti-inflammatory properties of macrolides have been demonstrated and may account for the utility of azithromycin in rosacea. Thus, these agents have been shown to inhibit neutrophil migration and chemotaxis through the downregulation of adhesion molecules and selectins and the upregulation of interleukin-8 and leukotriene B4 production, and to inhibit pro-inflammatory cytokines. Azithromycin has also been demonstrated to possess antioxidant properties through the modification of neutrophil oxidative metabolism and ROS production. Though rare, gastrointestinal adverse effects, typically nausea and diarrhea, are most commonly encountered with azithromycin. Overall, azithromycin is tolerated significantly better than erythromycin, also a macrolide antibiotic. Azithromycin is an FDA Pregnancy Category B agent. It also appears to be safe during lactation. Isotretinoin. The use of isotretinoin, or 13-cis-retinoic acid, in rosacea has been less extensive as compared to that in acne vulgaris. Nonetheless, this may be a valuable agent in severe and recalcitrant cases of the inflammatory subtype of the disease. In addition, its beneficial effect in rhinophema and rosacea fulminans, extremely treatment-resistant presentations of rosacea, has also been demonstrated. Isotretinoin is available as 5, 10, 20, 30, and 40 mg capsules and is administered once daily with fatty meals to improve absorption. As with acne vulgaris, numerous dosing regimens have been attempted in studies on treatment of rosacea. Originally, doses of 0.52 mg/kg/day have been evaluated and found to result in significant and long-term improvement in the inflammatory lesions of rosacea. However, since the condition tends to be chronic and typically associated with remissions and relapses, long-term or continuous regimens have been advocated by some authors. However, in order to limit the cumulative dose of the agent, low-dose isotretinoin therapy has been proposed. Such regimens tend to incur fewer adverse effects, though recurrences are common following discontinuation of therapy. Although not completely elucidated, the mechanism of action of oral isotretinoin in rosacea may involve its numerous anti-inflammatory and anti-proliferative properties. For example, isotretinoin has been demonstrated to inhibit neutrophil and monocyte chemotaxis, as well as neutrophil production of ROS. Furthermore, its anti-proliferative effect on endothelial cells has also been demonstrated, resulting in decreased angiogenesis. Future studies will need to confirm the relative contribution of these or other effects to the clinical improvement associated with the use of this agent in rosacea. Important pharmacokinetic data, an extensive review of the numerous potential adverse effects associated with oral isotretinoin, as well as several important drug interactions have been presented in Chapter 2 and should be revisited by the reader at this time. Oral isotretinoin is associated with severe teratogenicity and is, therefore, an FDA Pregnancy Category X agent. Its use in the U.S. is regulated through a stringent online monitoring system. Oral isotretinoin is also absolutely contraindicated in nursing mothers. World Medicine Universitet. 2017.